Okay, good morning, everyone. I'm Jessica Brutt from Cardiac Anesthesia, and it gives me great pleasure to introduce Dr. George Krasopoulos this morning. He's speaking to us from London. He's a professor of cardiac surgery and head of the aortic surgical program at Oxford, as well as the clinical governor for Oxford University Hospitals NHS Foundation Trust. He works as a consultant cardiothoracic surgeon currently at the John Radcliffe Hospital as part of Oxford, and has also worked in many institutions throughout the UK as well as in Greece. Beyond all his clinical and medical society leadership, he does private consulting and advisory with several firms and nonprofits. He shared his bio with us, and I just want to highlight his philosophy, if I may, George, which he outlined is based on offering surgical, medical, and humanitarian services of the highest standard. He's committed to ensuring that patients receive the best possible medical care, minimizing hospital stay and complications, and enhancing the overall hospital experience, practicing in evidence-based practice, and constantly striving to improve his ability to manage people and resources effectively. And above all, views teamwork as a fundamental organizational intervention around which institutions can re-engineer themselves for long-term competitive advantage and sustained excellence. He's connected to us this morning through the Transatlantic Education Network. We had a speaker last month through that as well. This network is run by the chair at Mayo Jacksonville at Archer Martin, as well as his collaborator in Europe, Gabor Erdoğan's. And this is a repeating annual series, which I hope Stanford will continue to be a part of. Without further delay, I'd like to hand it over to Dr. George Krasopoulos. Welcome, and thank you for joining us this morning.
Well, thank you very much, Jessica. Thank you for the introduction and your kind words. So, welcome everyone. I cannot see any of you. The only thing I can see is my screen, so please feel free to use the chat box to ask any questions or anything you may have. And of course, feel free to ask me questions at the end of the presentation. So what's this presentation about? It's about Oxford experience and techniques. I'm not here to teach you on how to do things. I'm sure that you're all very competent in doing it. I'm more interested in presenting what we're doing here, have a chat with you on how you do it over there. So me learning from you, you learning from us, and build upon this. Mm-hmm. That's interesting. The slides do not want to play. Oh, there you are. Let's go. These are my disclosures. If anybody's interested in them. Look into the aorta. For us at Oxford, we deal with the aorta as an organ. And I'm sure you do the same on your side. For us, aorta starts at the heart, finishes at the bifurcation. And despite the fact that we have cardiac surgeons, thoracic surgeons, vascular surgeons, interventional radiologists, cardiologists sometimes, playing with different parts of the organ, we tend to work close together. Let's rephrase on a few facts about brain, because brain protection especially is very important in the aortic surgery, and we all are aware about managing body temperature in order to protect the brain. However, there is no true consensus on what is the ideal temperature for neuroprotection during aortic surgery. Of course, hypothermia is widely accepted, but what is the actual number that we should go for? And that number, that temperature number has shifted a lot during my career. We invest very little in metabolomics, but I think that probably as we move forward and we understand better what we do, things will change, and these may end up playing a more important role on how we handle brain protection in the years to come. So what do we know? We know that success depends on patient selection. If you ask any surgeon, say, yeah, okay, if you pick up the right patient, probably you're going to have a very nice outcome. And the preoperative assessment is crucial to your success. Surgeon experience and expertise do play a significant role. And normothermia requires expertise from anesthesia and perfusion. Why I'm saying that is because at Oxford, we perform a number of operations with normothermia, and I'll take you through how we do it later on. And we're doing it because normothermia is, it does reduce the risk of neurological complications. And also, normothermia provides the most optimal condition for organ perfusion, as we all know. But we need to continue researching, and we need to continue improving techniques and understanding. So much for normothermia and hypothermia in complex aortic surgery, because these two factors are very significant for our success. And how we do it, I think what we do here today is it's a step to that direction. We do not exchange papers. I'm not intending to show you stats. I'm intending to discuss with you techniques, what we do here, and have a peer-to-peer discussion and freedom to explore various practices from our side and your side as well. Also, we have to understand that literature is got a problem. Okay, nobody talks about adverse outcomes in the literature. It's very unusual to find papers that they talk about adverse outcomes. Everybody's got a wonderful success, but they do occur, and we have to learn from those. So how do we do it at Oxford? Well, we have 2 or 3 multidisciplinary team meetings per week, and those are devoted to aortic diseases. And in those meetings, we have cardiac surgeons, vascular surgeons, interventional radiologists, imaging, anesthesia, cardiology, rheumatology, genetics, geriatrics, and specialist nurses. So we meet quite often. We discuss complex cases, and we're trying to find the best solutions. We have a dissection rota for the region with dedicated aortic specialists. So when a complex aortic dissection comes, it doesn't necessarily go to a general cardiac surgeon or a cardiac surgeon who does mitros. Or even if that person is on call, it's got a specialist aortic surgeon available to advise or even take over the case if it is very complex. And we have a super-regional standard operational procedures protocol for managing aortic syndromes, which expands to the entire south of England, trying to integrate services and integrate how we work within different centers, covering a large proportion of population of United Kingdom. So what I'm going to discuss is about what cardiac surgery offers at Oxford. I'm not going to expand to how we work with vascular or interventional radiology, and just keep it focused on the cardiac surgical side. So what we do, we start by talking. We have a long briefing period before we start the operation. We usually do it within the operating room. We making drawings. We discuss what we're going to operate. We try to make it simple. We try to make it simple so everybody within the operating room understands what we're doing, how we do it, and the what if. What if things go wrong? What are we going to do? What's the role of X, Y, Z within the team? What we're there to do, and that puts everybody at ease. Everybody knows what we're doing. Everybody understands, and everybody's engaged. So we deal with a variety of things. We deal with aortic abscesses and traumatic ruptures, so much because there is an endocarditis within the root, or we have a TAVI that has disrupted the aortic root. And we usually treat those with patch exclusion techniques. We have an extensive kind of experience in patching those areas extensively and trying to address them this way. We have access to homografts, so occasionally we use homografts, but the access is limited. We do not have endless number of those, and unfortunately, so much the traumatic, but also the endocarditis cases keep increasing every year. We do the bentos, as I'm sure you do it at your center. It's nothing much. I don't think it's something interesting or different that we do here that you may not be doing at your center. And we do more and more redos. We do come across quite often with cases where previous pendle operations are infected now and disrupted with complete dehiscence from the aortic root. And in these operations, we usually do LVOT reconstructions, and we replace the root, like on this case, where you can actually see that the actual operation has started within the LVOT and everything has been reconstructed all the way up. With the aortic aneurysms, we also do David procedures, and we try to work on the David procedures in combination with the echocardiographers, so much before, but also after the operation. It all goes to planning, making sure that we have the right numbers on geometric heights and effective heights, trying to make as much of plan ahead of proceeding with the operation, and then finalize it when we're there. When we do that, one of the important things is testing your end result. So how we test it, making sure that intraoperatively that the David procedure is working well and can be a durable result. Okay, we test it under pressure, but we also put the endoscope in, and we pressurize the root and see how the valve operates. So as you can see in the middle picture, we have two things that we test the end result. We test it with direct vision, we test it under pressure, and then we adjust it. We may be able to do extra repairs if they need to, and try to end up with a durable end result, as durable as we can make it. We treat a lot of aortitis. I don't know if it is my impression, but aortitis seems to be in an increase. Is it because we diagnose it more? I don't know. Is it because we have an increased number of aortitis in the modern Western society? I don't know. But when we looked into our results at Oxford, cases that they were presented and treated with complex aortic surgery and they had diagnosed aortitis either before surgery or at the time of the operation through the histology, those were the cases that had the highest percentage of needing a redo operation within 5 years, which is higher than Marfan's or connective tissue disorder that comes to mind first as patients that may need a second operation within 5 years. It was actually the aortitis patients. And these patients somehow, they lag in their therapy because there is not a clear understanding of how we treat it, what we treat them with. So at Oxford, we tried to invest into a system that we treat those patients, we monitor them for at least minimum 5 years. And we have a subspecialist rheumatology team that actually has been referred the patients for follow-up and therapy before or after the operation. And of course, we have the giant cell aortitis or any other type of aortitis. What we're trying to do now, having learned that these kind of patients that come with highest instant of needing a reoperation, and because macroscopically we don't know where this actually aortitis ends, it's very difficult to determine that. We're trying to be a bit more radical. So we're trying to eliminate as much tissue as we can. We think that it's pathological. And in that, we include also the aortic valve. If you go in and you see an aortic valve that may be working well, but it's very thick and it's been affected by the aortic process, especially if we know that the patient has been already treated for aortitis, we may have a low threshold of actually intervening to this valve because we know that that is going to give us problems in the years to come. With regards to the descending thoracic aorta, beyond the frozen elephant trunks, we do thoracoabdominals, but we tend to centralize them. So we do them at Southampton for the entire region, so we can keep the numbers high and we can keep the expertise within one center. With regards to aortic dissections, we bring everything together. So aortic dissections, we're trying to be radical, especially if an aortic surgeon is on call. So we do some interposition grafts, but when usually an aortic surgeon is on call and it gets a dissection, the patient it usually has what it needs rather than a rush in and out to just save his life. So this, what you see here is a patient who had the David procedure and he had the full replacement of the arch and proximal descending with a FET. So everything from the aortic root to the middle descending thoracic were replaced with preservation of his aortic valve. Actually, this patient, it's funny, the story, because he's actually dissected in Africa. And he was a marathon and he knew that dissected, so he jumped the airplane, he survived. He got in the first flight, he came to Heathrow, he got a taxi, came to Oxford and said, I've got a dissection, can you please call the team in? And yeah, he was one of those odd survivors. Nice story though. Now, let's go to the normothermic arch surgery. Right, okay. So normothermic arch surgery, there are two types. One is debranching. So we take all the head and neck vessels away, either intrathoracic by sternotomy or extrathoracic, i.e. we work on the head and neck. And then we stand across whatever we need to stand. But also we do aortic arch replacements, normothermic. So let's talk about this one. How do we do it? For us, the important thing is zone 2, okay? And zone 2 somehow is that zone of the arch that is, in my experience, the last that is going to expand and become aneurysmal. So it's the most stable area of the arch. So everything that is beyond the zone 2, okay, there are some techniques that they use normothermia with a very complex bypass exercises, but we don't do that at Oxford. Okay, if we end up with a problem that is at zone 2 and beyond, we treat it with frozen elephant trunks or thoracoabdominals or whatever the patient needs. But if it is up to zone 2 and proximally, depending on the configuration of the arch, we can do that operation normothermic. So over the past 24 months, we've done about 21 cases. There is a mix of different concomitant procedures that were performed. Patients stayed in the hospital for about 10 days, and generally they've done very well. So the important in doing the normothermic arch is all about perfusion. It's important to perfuse the body. And the minute that you establish perfusion to the entire body and you're happy with it, then you can do it. It's just end-to-end anastomosis from there onwards. So choosing which patient can have it. Not every patient can have it. it's very important to choose which one. But if the minute that you find that patient, the operation is a lot quicker, they bleed a lot less, they have a lot less neurological or any other events, and I tend to go home a little bit earlier and see my wife and children. So from the anesthetic point of view, how do we do the setup? We have BIS, we have cerebral oximeters, and for operations that we do beyond the arch or arch and beyond, we do a spinal oximetry as well. I'll explain to you later. Lumbar drains, we do it if we need it to the patient that we need it. We usually have 3 arterial lines, central lines, and for reduce femoral veins and always blood availability in theaters. For hypothermic cases, the anesthetists favor methylprednisolone, thiopental, and ice around the head. And for coagulation management, we use a protein. We usually aim for HB over 10. We use the usual stuff. We also use PCC and factor 7 if we need to use them, and we use them early if we have to use them. And that was the key, I think, in changing the from using the factor 7 when the patient is almost ready to die to use it early, use it appropriately, and our results are very good. So how do we do it? For us, we use axillary or subclavian artery cannulation as a key. It's the key thing for us. And we do that because by using the subclavian or axillary arteries, we get very good perfusion to various parts of the body. The approach is very easy. I'm sure you probably do it at your end. Effectively, we end up with a patient before even opening the chest looking a bit like that. We do this one with 3,000 to 5,000 units of heparin, and we continue flushing the lines so we don't get any blood within the tubes of the arterial lines. So we don't have any clots or anything there because we're not fully heparinized. And that gives us time to open up the chest, set up whatever we need to do in the chest. Everybody is secure and safe, including the patient. We use bladder temperature monitoring, especially for normothermia. We use continuous bilateral axillary perfusion or subclavian perfusion, but we also do the same for cases that they need a frozen elephant trunk. So we continuously perfuse both sides. For normothermia, we usually operate in between 35 to 36.5 degrees. Hypothermia, we currently are at 24 to 26 degrees bladder. Deep hypothermia, 19 to 22. How often we do it? Probably once a year nowadays. And on rewarming, we start as soon as the distal anastomosis is performed and the body perfusion is reestablished, and rewarm to 35.5 nasal and continue to rewarm until the bladder temperature comes to 36. So it's a bladder temperature that we're aiming for, and usually in between 36.5 nasal and 36 bladder is about a good half an hour to an hour time difference. But during that time, we always have things to do in the operating room, so we never stop, basically. Selective spinal drain usage. We use it when we have an issue with the spine, i.e., we have to put a stent in, a long FET in a very short patient, or we have to extend the stent, the FET very early if we need to do a thoracoabdominal. So those are the cases where the selective spinal drain is used. Otherwise, we tend to wake up the patient early, and after waking up the patient, if there is postoperatively a neurological problem, then we tend to put it retrospectively in. How we, as I said, we use 3 arterial lines. We use BIS and we use cerebral oximetry. But what we also use, we use the same cerebral oximetry put on the back of the patient, and those ones they measure the saturation around the spine. Often, why we're doing that? Because we perfuse both subclavian arteries, and those subclavian arteries, they have collateral perfusion into the spine. And 2/3 of the patients, I would say, you can see that the saturation on the spine remains high when you perfuse in both subclavians. There is a third or a quarter of the patients where the perfusion to the spine drops, or when you switch off the peripheral perfusion to the body, and there is no back bleeding, nothing from the spinal arteries, and those ones are the ones that we worried we have to rush the operation, or we need to think about spinal protection and various other things. So we measure the perfusion continuously. We measure the effect of the perfusion has to various parts of the body, and those help us to decide what we need to do with the patient, how fast, etc. On this here, what I'm going to show you is when we do a frozen left hand triangle work on the descending thoracic aorta, we continue to perfuse the left side of the subclavian. And then we put the camera in, and we assess the descending thoracic aorta. We look for thrombus, where we're going to put the stent and various other things. But also we look on perfusion. I'm sorry, but what you can see here, the analysis is not great, I'm afraid, is you can see this is a vertebral artery that is back bleeding. And you can see that when the flow is going down, it's bleeding, and now it's disappearing because the flow of the left subclavian goes down, and then the flow will come up again on the left subclavian, and then it will come back bleeding again. So when I see that, I know that my left subclavian is supplying quite a lot of blood to the spine. So I'm a lot more relaxed. If I don't see this one, obviously I have a problem in the circulation. Playing time of the descending thoracic aorta is reduced. Everybody should be focused, and we need to get on with the operation quicker. Excuse me. I'll pause for a second because I've got a machine outside, and I'm sure that it's interfering with the whole process. I'll ask them to stop it if possible. 1 second. Okay, apologies for this. I hope they're going to stop in a minute. So, when we have all this set up and all the perfusion to various parts of the body working, everything else is related to where the clamp goes and how you cross clamp, where the perfusion goes. And when you have everything set, the operation becomes simple. It's all end-to-end anastomosis, patient is safe, and everybody's happy. Intraoperative TOE, we use it. We have subspecialist TOE experts that they do the TOE for us. Some of the anesthetists, they are very proficient as well. And we use it to assess proximal distal graft dehiscence on the redo patients. We use it to assess intraoperatively let's say the aortic valve when we have to do a daily procedure, assess effective heights, cooptations, and everything, and also how the postoperative result, what the postoperative result looks. Again, evaluating once the cooptation surface, how durable is our repair, reporting the end result of the operation. And as I said, it's also important for us when we reach that point to put the camera in and look inside, see the end result under pressure, make sure that the cooptations is right. If it needs a little repair, like here when we repaired the one of the cusps, whatever is required to get the best, most durable end result. But we also use the TOE to assess our end result following frozen from trunk. Let's say on this case, we had a very big aneurysm. When we put the FET in, the stent didn't go down. It just flipped up and ended up on the back of the wall. So we had the information immediately from the TOE, and then we end up putting a TVAR in with end result looking, as you can see here, with almost the entire descending thoracic aorta stented, and the patient did fantastically. But without knowing where the stent sits, it may have been hours before we realized with another CT the aneurysm may be pressurized inappropriately, ruptured, had a complication. So the TOE helps us in many ways in theatre. The other thing that we do at Oxford quite often is we are very liberal with the tricuspid valve. Especially if you have an aortic root aneurysm, what you usually get is that you get this area of the aortic root tricuspid confluence pushed towards the tricuspid valve. So if you have an annulus that is dilated and it's got mild to moderate MR, we set up the patient ready to go for a potential ring. And that helps us in general because the right heart, which is usually a bit sluggish after a prolonged bypass time and long operations that they go over the 10 or 12 hours, it performs a lot better when it doesn't have massive TR at the end of the operation. So the patient usually comes off bypass with a lot less inotropes, and the recovery is a lot faster. So at Oxford, we have a team of people. We try to work together. It's every member is important to us. Everybody needs to understand what we do, and we work. Our work is based on trust, based on communication and comprehension. Everyone should understand what we're doing, and everybody should be cool with it. If somebody has a question, if it doesn't understand something, we have time for people. Complex aortic surgery, I think, depends a lot on good perfusion and understanding where the perfusion goes, how it works. It's a key part. And of course, plenty of proline switches. And occasionally a hand with a drink when the operation goes beyond 12 hours. So thank you very much for your attention. I hope that I've given you a little bit of insight on how we do it at Oxford. I'm happy to accept any questions you may have and see what I can learn now from your side. Thank you.
Thank you so much, Dr. Krasopoulos. That was fascinating. I'll help moderate the questions in the chat. Is just Michelle's administrative notes. I would like to understand this camera a little bit more because I've seen it on some like online resources in kind of wet labs, but I haven't seen it used applied clinically. Can you tell us more about when you first started using that? Does everybody use it, or is this a Professor Krasopoulos special? How do you apply it?
So it's not, I didn't invent the whole process. I've actually picked it up from others. I've just adapted on what we're looking at. There are a lot of people that they put, you take a bronchoscope, we usually use a flexibronch that our thoracic colleagues use. And we use it on two directions primarily. One is in the aortic root, as I show you, and that is by putting it through the graft, clamping the graft, and then using crystalloid cardioplegia to pressurize the graft. So that's why we can see what we're doing. And we use, I don't know, 500, 600 mils of crystalloid cardioplegia. And you can see very quickly, comparing TOE, direct vision, your understanding on what your end product is from David, and you know exactly what you need to do. Otherwise, the TOE gives you a two-dimensional, where is exactly the leak, or if there is a little bit of prolapse on one cusp, you can pick it up very quickly when you look at it with the camera. And the other thing is, when we go into the descending thoracic aorta, it helps us in many ways. One is when you have a dissection, you can actually have a look to see where your secondary tears are. We do it when we have, we go into kind of what we call a circ arrest, i.e. undergrade. We perfuse undergradely, but we do not perfuse the body. And at that point, we may drop the flow to the subclavians so we don't have a backflow. And when you put it in, you can see your secondary tears. You can guide your stent down the true lumen if you need to. You can assess the back bleeding from the intercostals or how much bleeding you have back. So it gives you a lot of information, and it's very easy to be done. It's extremely easy. It adds 5 minutes to the operation, but the understanding on the surgeons on what exactly they do and why they do it, and the understanding of the wider team of, well, what have we done here is great.
And then you mentioned one of the reasons you use it is to look for thrombus. What do you do if you see thrombus? Because it's not uncommon you find some thrombus or developing clot in the false lumen particularly.
Yeah. So when you get and you see the thrombus, it's just again guiding. If you have to guide your stent, if you put it blindly, no matter how you fix the frozen elephant trunk, the minute that you put it in, you may start scraping things from the wall. So if you put your camera in, you know where your thrombus is, then we usually put the camera along with the FET, and they go together down, trying to avoid scraping the clot off the wall, minimizing any traumas that you may have, avoiding putting the FET through a fenestration or something. You know, there are a lot of things that can go wrong if you do things blindly.
Yeah, so many opportunities for misadventure. A question from the audience is, how do you interpret the cerebral oximetry numbers on the back, and what interventions do you perform?
So, yeah, that's a great question. So this is something that we continue to learn. And that is something that we developed here in a way as an idea. It's surprisingly how many patients that have consistent saturations with no drop on the saturation when you perfuse the left subclavian. The minute that you stop perfusing the left subclavian, those saturations go down on the floor. So it's like doing an arch with no undergrade cerebral perfusion. You are totally relying in how fast you stitch. If you perfuse the left subclavian and you have stable saturations, more or less the same saturation you get on the brain, you get on the back. When you get that, and you put your camera down and you can see your intercostals back bleeding to you, you can take an hour. We have taken an hour and 10 minutes to do a distal anastomosis because it was very complex, a lot of tears, we have to manage a lot of things. Patient woke up, no problems anywhere, no brain issues, no spinal issues. So it helps to treat. Now, if you get a patient that you perfuse in both subclavians and your saturations, they drop to nothing. It happened to me once or twice per year. You get the patient here, you perfuse the left, the minute that you stop the circulation to the rest of the body, saturation disappear. You put the camera down, no back bleeding, okay? Here, it's time, okay? We have to rush because the spinal cord doesn't get any blood.
All right, so you don't have any magic solution for that specific problem. You haven't found a way to tinker or put some other perfusion somewhere. Okay.
No, we don't do anything else. I perfuse through the through the leg or anything else. We have done it, but what we find is that probably less than 10% of the people need it.
Yeah.
90%, the minute you perfuse the left subclavian, you're fine.
Everything looks golden. Yeah.
And you have evidence to prove it.
That's nice. Do you, from a practical perspective, do you need to put extra padding where the sensors connect to the cable? How do you minimize the risk of pressure injury?
Yeah, so we because they're different connectors and some of them they're quite bulky. So we do a little bit of padding there and make sure that we don't get a pressure injury. That's why we don't use them. We don't put them all the way down, or we don't do multiple levels. We do it in between the spines, and then the two heavy bits, they come a little bit further up.
Yeah, it looks like you're using the Medtronic Inbus, which is what we have as well.
Yeah, I don't use the Medtronic anymore. Actually, I moved on.
Oh, so not the images that you have. What do you have now?
I know, because the one I don't use them. I don't want to go in the companies, but I use a different one now because I found the Medtronic. When you cool down, it has a tendency to come off and becomes unreliable. So we use a different one. I don't want to get into.
Which is just more sticky when patients are cold. All right, interesting.
Yeah, so it gives us a lot more consistent readings when the patient is cold without coming off the skin or anything else.
Another question. I have two more questions actually, and plenty of time. Thanks for leaving the time. Where do you place the 3 arterial lines, and what do you do if or when the hypothermia generates different maps from the 3 arterial lines? I imagine bilateral upper extremity and femoral, but how do you manage that?
So there are 2 radials and 1 femoral. Those will read different numbers. Numbers mean nothing. It's all about perfusion. So because we use side branches, the 2 arterial lines on the hands that helps us with the perfusion. So the perfusion is manipulating the perfusion in order to obtain flow to the brain, but also maintain blood pressure to the arterial lines, even on circulatory arrest in between 40 to 50. When you go into body circ arrest, obviously you lose your femoral, but you maintain the radials. When you are in the full perfusion and reperfusion, you may end up having different perfusion readings. You end up with more. You end up with more exacerbated differences when you have only a right subclavian or a left subclavian and not bilateral. When we do a lot of aortic work, they don't need bilateral necessarily. We do only with a single one. You put a single one and you perfuse through, let's say, the right. So your right will be reading 80 millimeters of mean. Your left may be reading 40. Your femoral may be reading 50. But it doesn't really matter. If your perfusion is good, this is what matters, not the actual number.
It's not the number, it's the perfusion. That's how bread and butter. All right, this is an interesting question. Do you ever have to pivot from a planned normothermic arch case to a hypothermic arch case based on numbers, data, perfusion, anything else that's going on intraoperatively?
Yep. So what happens, as I said to you, what the important thing is perfusion. So if I start, let's say, a plan that I would do a normothermic arch, set up everything, I guess, okay, we're ready. I'm going to put my clamps on. And then I'll wait for a 1-2 minutes when I'm pleating the heart, whatever. And I'll have a chat with the perfusionist, have a chat with the anesthetist. Hey guys, what is happening? Oh, I've lost, my perfusion has gone down. I've got a problem. So that's fine. If your perfusion is not right during those 2, 3, 4, 5 minutes, take the clamp off, cool down. We cannot do it. It's not an exercise to prove if you can do it. If you can't do it, your perfusionist and anesthetist will tell you you can do it. From there onwards for the surgeon, end-to-end anastomosis for properly.
Wonderful. Well, I think we've given you ample time for questions, and you've given us a real thought exercise on reflecting on what we do here locally and how we could do things better. Honestly, the team planning exercise that you illustrated as part of before you even open the chest, before you even put an anastomosis on, is inspirational. And I hope the cardiac anesthetists who are on here, cardiothoracic anesthesiologists, sorry, who are on here, together we can perhaps take this to the surgeons and use you as an example, or your team as an example to modify our practice here.
Fantastic.
Thank you very much. We've very much enjoyed the talk this morning. Thank you for your time. Everybody have a wonderful Monday, and we look forward to meeting again.
Wish you all the best.
Thank you.
Take care, bye.